imitation from Professor Zalali and Professor Gore. My topic is about the mechanism of basilar invagination, or why is it inducing Atlanto-Axial Dislocation. This is my hospital, Xuan Hospital. This global building is the neurosurgery department. We call it China INI, International Neuroscience Institute. This year, in September, we will organize WFNS this year in Beijing, and the opening ceremony will be on the Great Ball. So it will be a glorious congress. If possible, come to Beijing. Let's talk about something about the C1 and the C2. C1, C2, there's a three part between C1 and C2. The central part and the bilateral facet joint. Usually we emphasize the central part. The lateral part are easy to be not so emphasized. When there is a stable and even dislocation between C1 and C2, there's two kinds of dislocation. The first dislocation, there's no basilar invagination. The second, there's dislocation, but also accompanied with basilar invagination. When there is no basilar invagination, we can see the central part of between C1 and C2 dislocated. And we can also see that bilateral part of the facet joint also dislocated. So it's will dislocated totally between C1 and C2. But when we talk about the Atlanto dislocation with basilar invagination, you can find that it's different. In the central part, there's a little dislocation. But on the bilateral facet joint, they're just deformed, but there's no dislocation in this part. So there's some difference between dislocation with or without basilar invagination. Why? Some pathological factors like trauma, also odontoid, they first destroy the central part of between C1 and C2, causes the dislocation between C1 and C2. So the lateral part are also dislocated. But the basilar invagination, the pathological factors first affected the lateral facet joint, the deformity here, and later by later, they're dislocated in the central part. So these two kinds of disease there's some difference. What is the reason for congenital basilar invagination? It's very unique disease. It's very popular in East Asia, North Asia, in India and in China, but very few in other continents. When we talk about this kind of disease in America and Europe, most of the doctors do not know it. This is a normal person. He does not suffer basilar invagination because occipital C1, C2, they are normal. But when congenital basilar invagination, we can see most of these cases suffered occipitalized of C1. C1 disappeared, vanished. So the height of C1 disappeared. C2 moved upward into the cranial. This is the reason for congenital basilar invagination. Some of the basilar invagination will not happen C1, C2 dislocation, but some of the basilar invagination will induce C1, C2 dislocation. Why? There's a lot of other articles, just like idea of Gore. Solanki also have the same idea. There is a deformity between the facet joint and like lysis in the lumbar region. It causes the cranial gravitational center move forward, and so the lower spine the lordosis of lower spine should be increased to compensate, to balance this gravity move forward. So the C1C2 become dislocated. And also, some research from China also found that with the 3D CT scan, they found if the deform between C1 and C2, lateral face joint, more severe, the dislocation between C1 and C2 will be more severe. And Condor also focused on the lateral face joint. He measured the face joint, how he gives a degree of the face joint, how it deformed. He found that the sagittal inclination of basilar invagination subject and also the cranial circle tilt, both of the factors increased in the basilar invagination with Atlanto-Axial Dislocation. So it's obvious that the face joint is the most is the reason for basilar invagination induced Atlanto dislocation, but it still does not explain why C1C2 dislocated. Later, I found that they're not only deformed on the lateral part, but also in the central part. In this kind of patient, I observed that the odontoid also deformed. We all know that the central part of between C1 and C2 is very important. Keep the stable between C1 and C2 in sagittal plane. If the odontoid deformed, even disappeared, so of course it will become unstable and even dislocate. But really, is it? So I collected some of the images from normal control, and some basilar invagination patient, some basilar invasion accompanied with Atlanto dislocation. I collected the CT scans, and this is the data from three group. The three group, the age and the gender has no difference between the groups, and I calculated the ratio of the odontoid between the height and the width to judge whether there's a deform of the odontoid, and also the face joint sagittal inclination, and the chamber line, and cranial cervical angle, and also ADI. Also these characters. From a sagittal view, I measure the cranial cervical tilt, and also the chamber line, whether there's a basilar invagination. On the lateral sagittal view, I measure the sagittal tilt of the lateral face joint. On the coronal view, we measure the height, the ratio of the height and the width of the odontoid to define the deformation of the odontoid. And in the axial view, we measure the ADI to judge whether there's a dislocation between C1 and C2. This is data of the parameters. And we found that there is thus obvious difference between these three groups of the ratio of the height and the width of odontoid. So that means the odontoid, the form of odontoid is totally different between in these three groups. And we also found that these parameters is correlated with the severity of basilar invagination. And the height of odontoid and the height and compare with basilar width also related with the dislocation between C1 and C2. With the ROC curve, we analyzed that if the height of odontoid is smaller than 11 millimeter, C1, C2 dislocation will probably happen. If the ratio of between the height and the width of odontoid smaller than 1, the dislocation will happen between C1 and C2. I published this article last year. So what happened in the congenital of basilar invagination, the reason is C1, also occipitalization. This is the reason. And if the lateral first joint and the odontoid does not deformed, there will be no dislocation between C1 and C2. If the lateral first joint deformed and complied with the deform of odontoid, then there will be dislocation between C1 and C2. It's very important to understand the deformity of the odontoid. For in this kind of case, very severe deformity between CV junction, it's no possible to reduct from posterior or anterior. So what we can do is resect odontoid resection to decompress from anterior. Usually we call this odontoidectomy. We should remove this part of bone to get a successful decompression. But if we look at the corner view, you will know that the odontoid only this part. What we removed is a part of the vertebral body, corpectomy for C2. After operation, we get a decompression, and what we decompress is on C2 vertebral body, not only odontoid. So we should not call this operation odontonectomy, but corpectomy of C2. Thank you.
Any questions for Zan? Yeah, ma'am.
Very nice study, actually. We had difficulty to understand the deformed odontoid process. This can explain why it happens. Probably because of too many movements, it is deformed.
Yeah.
What do you think about the fixed deformity and non-fixed deformity? Are there cases that we cannot reduce with surgery?
Yeah, there did some.
Especially, you have shown in the last case,
Yeah.
there are new bone formation on the tip of the odontoid that may avoid us to reduce the dislocation. What do you think about it? Atul is completely against this. I know him, but what do you think?
Yes, in fact, in next lecture, I will explain why some dislocation is irreducible. In my opinion, there is 2 factors. First, the deformity of the first joint. If it locked together, it's hard to reduce from posterior. And the second is that something we cannot see on CT scan and MR scan. It's a soft tissue. For there is a cell ligament on the odontoid. We know this and also anterior sulcal, some muscle anterior the sulcal spine. This kind of soft tissue will prevent us to push the C2 out of the cranial to reduce the basilar invagination. I think this is another factor for irreducibility.
You
Yeah, yeah. They did some usually.
Comment on that.
Okay, Zan, whilst, whilst Max comes, thank you very much, Zan.
Okay, thank you.
Now just to comment on that, you see, there were several entities in craniovertebral